welcome and a very good morning to all the participants. Welcome to the AicQoL2026 Jakarta Conference. Yay. Right now, at the location of the Sunlake Waterfront and Convention Center. And thank you so much to everyone who came here today. The program is as follows, if you can see on the back of the tags. Yes. Okay. So the first breakout chat will be Prof. Ranjith. The second breakout chat will be Dr. Shona, and the second will be Professor Bugaya Guy. Okay. And today joining us is first our conference chair, Prof. Yusuf, and also the president, Dr. Wanasha. And today I'll be your MC and also director for this committee wide. Okay, so without further ado, the national anthem first. Okay, so I would like to ask everyone to stand up for the national anthem. Macam pergi ke sekolah tak? Okay, thank you. Now I would like to ask everyone to sit down. Thank you. Thank you for sharing your amazing voices. Anyway, next next up, we will start off with our opening speech by Prof.
Assalamualaikum warahmatullahi wabarakatuh. Greeting from Jakarta. Tak dengar. Ada the mic. Okey, sekali lagi. Assalamualaikum, bismillahirrahmanirrahim. Terima kasih. Thank you very much for attending today's conference. May I have a raise of hands for those who joined us in the last conference in Charity? You attended our yeah? Oh, London. Any more from London? We got one from. Okay, we got one from still from Paris actually. Madam President stuck in Paris. Anyway, again, syukur kita keadaan ilahi kerana dengan izinnya dapat kita datang berjumpa sekali lagi di sini. Dan this is the second Jakarta. The first Jakarta was way back, tak tahu lah, almost about 8-9 years ago. So this is the second Jakarta. Of course, in Indonesia, quite a number of cities that we've been to. Right, back to for Jakarta today now. Alhamdulillah, yesterday we had a virtual presentation. It was very smooth. No, it was smooth. Yeah, no hiccups, and was a lively presentation for those who managed to attend. Lively presentation and discussion, and of course the second breakout, somehow it exceeded. Of course, normally when the argument is heated, it just even the breakout chair got carried away at the time. Anyway, alhamdulillah, it was worth it. I hope, hopefully, for today, no hiccups. Yeah, our hiccups normally with the Wi-Fi and the connection and so on. And also, we are connected with Australia for the first breakout chair, and then with Tehran, the second, and the third with Kuala Lumpur, Malaysia. So hopefully, inshallah, we pray that everything will be smooth. Just a briefing for the what we have in store for today. Here will be your coffee dust diet. Your lunch and dinner will be on the first floor. Dinner second level. Second level. The level 1 will be the lunch, the restaurant, and also for the dinner, barbecue dinner. It's actually same entrance to the lunch, tapi dia swing on your right towards the swimming pool. It's just that regarding the barbecue dinner, they unfortunately or fortunately that they have their weekly barbecue. Jadi when to accommodate our activity, they cannot have a separate private forest. Okay, so the beauty is that the food will be much more for the public, but they have allocated us our space. Jadi for dinner, make sure that you are seated at our place, because that's where the certificate presentation will be held. If you sit all over the place, I think it's going to be quite difficult to get your. So make sure that you are seated. There actually, if you walk, towards the swimming pool, it's actually on the left. They are reserved. Our seats there. And this is very important because you'll be mingling with the public. And then of course they charge the public. So please take along with you, especially for meal time. For meal time, this is quite important. It'll be awkward if the security, just stop you. Right. I cannot speak much because this is just a welcoming. So I will be discussing and more things to talk about in the post-conference session to be held on Wednesday at 8 p.m. Malaysian time. So there's a lot of things to say. I'll say during that time. Okay. Just an update. I got a shock last night that I received a message from the Arabian regarding our WoS index. Now, so far we have got it automatically, meaning whenever we organize conference, we can put the WoS as index conference. Okay, but starting from 2026, they have updated they updated their criteria. Okay, so it will not be automatic anymore. Meaning we cannot say for the next conference in Sarawak, sometime in March, April, we cannot put as WOS index. The indexing comes after we submitted. So it is a challenge for us because pertama, there will be lesser papers because we are not sure that it will be indexed. So I assume that there will be lesser papers, or for that matter, there will be no more papers for the next conference. I'm not sure because they will index only after the conference. Jadi I argue with them that it's very difficult for us actually to organize when it's actually post conference then only index. Okay. Anyway, I'm waiting for their response. So that's the latest that I had last night from Arabian. Okay. But whatever it is, the outcome, because I'm still arguing about the same. So whatever it is will be released when we promote the Kuching conference. It will be displayed there, whether it's automatic or it will be clearly stated that the indexing would be after the conference, and we are not sure whether it will be indexed or not. Okay, so that's when the finalization that they will be displayed on the in the poster and also on the website. Okay, so I'm not sure for this as well because they start the conference starting from January 2026, meaning this is going to be published in January, meaning that even this one, if they activated what the updated version, meaning this conference also might be affected. It's not automatic, meaning they have to go through again. You realize what I'm trying to say? Okay. Before this, I was automatically indexed. Okay, starting from 1st of January, they have new criteria and they have to evaluate every proceeding that we publish. So we after we publish only, then we submit to them, and then they will decide whether they want to index or not. They have their own criteria and new management and that sort of thing. So to cut it short, if I get anything positive or negative, for let me tell, it will be announced during the post-conference meeting. Okay, so more updates during our post-conference on Wednesday, on the 7th. Okay, so please be there. Now for the post-conference meeting, the most important thing, apart from the best paper award, would be how not to be surcharged. That is very important because we're going to have a one-to-one tutorial session. We do not want to surcharge you, but we want to move fast. Okay, so if you comply, no problem. But if you do not comply, we don't have to surcharge you because we have to move forward. Okay, so please attend this conference because we have the one-to-one tutorial session. So that we go through each paper slowly, so that you understand the things that we wanted as in terms of compliance. Okay. Right, with that, thank you very much, and hope we have a lively conference for today. Over to you, Adi.
Okay, thank you, Prof. Thank you so much, Prof, for your opening speech. Okay, next, Prof Arct hasn't logged in yet, so it's okay. Now, I would like to move on to our next agenda, and our welcoming speech by our President, AMER President, Dr. Wan Asham.
Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli wa ufawwidu amri ila Allah innahu basirun bil ibad. Distinguished AMER Conference Chair, Honorable Professor Dr. Muhammad Yusuf Abbas, respective AMER board members, members of international scientific committees and editorial teams, fellow professors, doctors, conference different participants. Ladies and gentlemen, and a very good morning to all. Welcome to Jakarta. Have you finished shopping? Right after this. So it's my great honor to privilege, I welcome all of you to the 14th AMER International Conference on Quality of Life, AicQoL Health here in Jakarta. So this conference is actually organized by Association of Malaysian Environment-Behaviour Researcher AMER, and this marks our 52 WoS-indexed as mentioned by Prof. So it's going to be only selected papers. After the conference, then we will index in WoS. This shows the testament and commitment to advancing our research and fostering collaborations across borders. So this year we are proud to host participants from 10 countries with a total of 49 approved abstracts and 36 full papers. So this actually reflects a strong spirit of international cooperations that we have. And notably, the majority of contributions are joint effort between Malaysia and Indonesia. And alongside, we also have colleagues from China and Philippines, Thailand, Iran, New Zealand, Nigeria, Turkey, and the USA. So our team emphasized quality of life, a concept of resonate deeply in today's world, and the paper presented span 14 subcategories. So with a significant focus of health and healing environment, education and learning environment, design and creative environment, and these are all the discussion will not only enrich our understanding but also inspire innovative solutions for a better future. So I would like to express a heartfelt gratitude to everyone who has made this event possible. So this includes the international scientific committees, breakout chairs, editorial teams, all the crews, and of course all authors and participants. Your dedication and to ensure AicQoL2026 remain a platform for meaningful dialogue and impact for research is really, really appreciated. So wishing you a productive and inspiring conference ahead. With Bismillahirrahmanirrahim, I declare AicQoL2026 open. Thank you.
Okay, thank you so much, Dr. Arsham, our President and Technical Professor. Now, while we wait for our first breakout chair to come in, everyone, you guys can, sorry. Yeah, we can start with the first presenter. Now, and the rest, you guys can
Continue working.
yeah, continue with your coffee. Get your coffee. Okay. Does anyone understand? No one understand. Smoothie blood. Any questions?
So get the first speaker ready.
Okay, so the first presenter?
Over to you, Mr. Wafi.
Alright, very good morning. Thank you, Dr. Suryato. So, my name is Roman Wafi. I would like to present for inclusion criteria. So, the adult age is more than 18 years old undergoing for elective total hip arthroplasty. Nurse-led pre-operative education such as counseling, group session, multimedia like Facebook or Telegram or telenursing, outcome reporting pre-operative anxiety and or post-operative pain, hospital or ambulatory surgical setting, quantitative, qualitative or mixed method study, and published in English or Malay within 2020 to 2025. So the key finding and the discussion, nurse-led pre-operative education was cautiously effective in significant reducing patient anxiety before surgery. So the impact on the pain was less consistent. Some studies showed lower pain and opioid use, while others found a weak or indirect relationship. For interactive and structured methods work best, group classes, multimedia teaching, and telenurses sessions that encourage patient engagement were more effective. For culture adaptation, improved outcome. Education delivered with culture sensitivity in familiar language resulted in greater anxiety reduction and higher patient acceptance. For the Malaysia, we use for the Malay language can reduce the anxiety. So reducing anxiety indirect helps pain management. Collective evidence suggests that improving a patient emotional preparedness education contribute to the better pain control, shorter recovery, and higher certification. For recommendation for the healthcare practice, first is integrate education into the standard care. Make a structure, nurse-led education, routine and perioperative pathway, especially when enhanced recovery after surgery errors protocol. For the standard and tailored education content, develop standardized, interactive, culturally adapted modules involving the patient family for persistence and effectiveness. Focus on future research, use as standard measurement tools, embed digital telenurses platform and conduct research in your local and context, such as Malaysia. So for the conclusion, nurse-led perioperative education consistently demonstrate positive effect in reducing preoperative anxiety and enhance psychological readiness for surgery among patients undergoing elective total hip arthroplasty. So this is my reference.
Thank you. Thank you very much for that very interesting presentation in regard to the management of anxiety and pain in post-operative total hip replacement therapy. I have a quick question to raise from the research, but before I raise any questions, I would like to open the floor for discussion. If anyone in the audience has any questions to raise, please. Is there anyone in the audience who has anything to raise in terms of the outcome of the research or methodology or whatever aspects of the research? Is there anyone in the audience? No? Doesn't look like there is anyone in the audience who wants to raise a question, but I have actually a couple of questions. Number one, the presentation was titled about anxiety and pain in the post-operative situation of hip therapy, hip replacement. And the first issue is, of course, the number of papers finally screened down came to a very small number of 11 out of a very large number at the beginning, which is to a certain extent inadequate to actually make a sufficient judgment about the relationship that were being established. This is number one. But more importantly, although the title suggested management of anxiety and pain, I think, as to be understood, pain actually may not be really dealt with through the proposed solution that you are raising, which is education of nurses. That is primarily because pain is a neurological sensation, and nurses are outside entities who cannot really intervene into the neurological sensation of pain. So what do you say about that? Anxiety I can understand. Anxiety can be managed by psychological influence brought about by the nurses and the nurses care. But the pain is a bodily production, a neurological sensation, and I don't think pain can actually be influenced by anyone outside, however care you provide. What do you feel about that?
For me, that pain can be reduced by using any medication such as opioid. But for me, after the procedure for total hip arthroplasty, such as another 1 week for procedure this, patient will overcome with increase for pain. And then for the hospital, in the procedure, we use like we have something like such as pain APS, acute pain service. For the pain, I think it will become more increased, because after the procedure of the total arthroplasty, after the 24 hours, patient must be ambulate. So pain will become more strongly.
Yeah. Right. Okay, acceptable. That explanation is a good explanation, and thank you very much. Thank you very much for that presentation and focusing on the aspect of initiative hip therapies. Thank you very much.
All right, thank
We
you.
move on to the next presenter, and the next presenter is HE002. Nur Shahiza Mohammed Fatih and Riza Kusuma Undurani. He's going to talk to us about relationship of anxiety again, physical performance and sarcopenia in older people with low back pain. A similar situation, but low back pain. Over to you. Thank you. Let's start.
Okay, Assalamualaikum and good morning to respected chairperson, reviewers and distinguished participants. My name is Nur Shahiza binti Muhammad Fatih from University Technology Mara, and this study is conducted together with my co-international author Riza Kusuma Undurani from Universitas Pembangunan Nasional Veteran Jakarta, Indonesia. So today I am honoured to present our scoping review entitled The Relationship of Anxiety, Physical Performance and Sarcopenia in Older People with Low Back Pain, which is a scoping review. So next we move to the introduction. So low back pain is the one of the prevalent and debilitating condition in older people. Almost 40% of older people experiencing impairment in daily functioning. So the impact of low back pain is interaction of musculoskeletal, psychological and performance-based factor. So prolonged pain often leads to inactivity, which accelerate muscle loss and increase vulnerability to disability. So at the same time, physiological distress, intensities, pain and hinders rehabilitation in older adults with low back pain. Okay, the main objective of our research is to explore the relationship between anxiety, physical performance and sarcopenia in older people with low back pain. But the sub-question is what is the relationship, and so what gaps in evidence, and what is the extent, range and nature of evidence regarding the relationship between anxiety, physical performance and sarcopenia in older people with low back pain. Okay, chronic low back pain is driven by physical and psychological factors and worsened by inactivity, commonly in population of older people. So aging leads to sarcopenia, which is when reduce in physical performance and increase the anxiety. So sarcopenia definition is age-related, which is age-related reduce in muscle mass and function, so hence lead to the chronic pain. When we come to disability, that can reduce the quality of life. So we conducted our study using framework ACT and O'Malley and Prisma extension for scoping reviews. So database from PubMed, Scopus, Web of Science and Google Scholar. The inclusion criteria is article written in English, participant age 60 years and above, which is diagnosed with low back pain, and we measure of anxiety, physical performance and sarcopenia. So after screening and exclusion, 9 study only included, which is cross-sectional studies only. Okay, this is summary of finding. So most of the studies were cross-sectional in design, which is assess physical performance using gait speed, grip strength and functional test. So sarcopenia was using established diagnostic criteria, and anxiety was assessed by validated questionnaires. So however, only a limited of studies examine these variables together. So next, I will pass to my partner, Lisa Kusuma Anggraini there.
Thank you very much.
Okay, thank you. Thank you for your presentation.
That's an interesting study about the issues of low back pain. I have a couple of questions, but before I ask any questions from you, I would like to open the floor for discussion for anyone in the audience who may be experiencing low back pain. Could raise some questions. Low back pain, unfortunately, is not a matter only for the old adults, although this particular study has focused on the old adults. I wonder if anyone in the audience is
I have questions. One, why do you choose cross-sectional study? Why do you specifically choose cross-sectional study? And for the sarcopenia, are you measuring all the lower back muscles for the sarcopenia, or there is a specific muscles for the sarcopenia for lower back pain? And the third one, which exercises that you prescribe for the sarcopenia patients?
Thank you for the question.
Okay, for the first question, why I choose the cross-sectional studies. Okay, so for the first question, because I think the cross-sectional studies, which is combined interaction that more comprehensive framework and supporting the integrated clinical decisions making. So for the second question,
Why do you choose, which muscles that you choose for sarcopenia? Is there any specific muscles?
yes, for the sarcopenia, we just access first calf circumference, okay, and next hand grip strength. Hence, after that we use also SAC-F questionnaires, and then we combine for SAC-CAF questionnaires. So that's the reason why I choose the sarcopenia assessment to make a clear decision. So for the next questions, which is
Which exercise? What type
okay,
of
exercise. The first one is for hand grip strength, combined with CBT, cognitive behavioral therapy only, and then we choose for psychological exercise also, and then we add on for muscle and physical performance activity such as hand grip exercise, okay, calf exercise, which is lower limb and upper limb also. Okay, that's all.
Thank you. Are there any other questions? No, it doesn't look like there are any other questions, but I have a small issue that I want to raise with you, particularly with regard to the outcome findings and the conclusions that you made. In the title you said you were going to establish this relationship between low back pain, anxiety, physical performance and sarcopenia. However, I have to admit that you did not really establish a relationship. You just said that there is a relationship. From a research point of view, first of all, the number of 9 articles being reviewed is inadequate to make a value judgment from a quantitative point of view. But nevertheless, you should have reported how many out of these 9 actually established this relationship strongly or poorly or otherwise. Otherwise, your title does not necessarily reflect what you were claiming, that you were going to establish a relationship. To begin with, you understand that there is a relationship, there is no question about it, because that's why you conducted the research. But your claim was that you were going to establish what kind of relationship actually exists. So I'm afraid you should, next time around, establish that relationship and see what is the relationship. Is it strong, poor, mediocre, or nothing at all? You might want. Thank you very much. Thank you for the presentation. Thank you. Let's move on to the next presentation. HE003, which is Sushi Wahyu Ismail Sa and Hilmi Zada Faidullah, who are going to talk to us about the influence of demographic, occupational and pain intensity on low back pain again among office workers. That's an interesting point. Please, over to you. Low back pain again amongst the pain.
Good morning, ladies and gentlemen. Thank you for the opportunity to present our study. Today I will be sharing with you our findings about demographic occupational pain intensity on low back pain among office workers. Low back pain is a growing global health burden. Worldwide, the number of people affected increased from 90% in 1990 to 2021. In Indonesia, 40.5% of the population experience of LBP. Office workers represent a particular high risk group due to prolonged shifting, altered spinal loading, muscle imbalance, often accompanied by workplace stress and poor ergonomics. This raises a critical question. What matters more, who you are and how you work? This question forms the basis of our study. This study aims to investigate the influence demographic characteristics, occupational factors, and pain intensity on low back pain among office workers. And we had three objectives. The first one, identify demographic factors of LVP. The second one, examine occupational and pain-related risk factor associated with LVP. And the third one, determine which factors independent predictors of LVP. In the previous study, show that low back pain in office workers is influenced several key domains. Prolonged sedentary work, high job demands and stress, low physical activity, and poor sleep do contribute to cumulative mechanical and physiological strain on lumbar spine. Female workers have been reported higher risk, represent related hormonal factors and degeneration. Excessive body weight, increased lumbar mechanical load, and microtrauma, which may lead chronic pain progression. In addition, higher pain intensity is associated with persistent LVP and nociplastic pain mechanism. Together, this finding guide the selection of variable examined in our study. This study using cross-sectional observational study with strong guidelines and ethical approval from UiTM and UTCG, who has include adult 18 to 60 years, independent ambulance and stable comorbidities, and exclude unable to maintain upright posture, major spinal, recent subspinal surgery, and current LVP. LVP was defined based on self-reported work-related symptoms without requirement prior medical diagnosis. And pain intensity using numbering rating scale, anthropometric, and occupational factors were also collected. Statistics was performed with SPS Extraction 25 and including description analysis, group comparison, predictors with multivariable logistic regression. And total, we have 105 participants, include 64 LVP and 41 without LVP. Sample size, mean visibility, and given per variable requirement. And this slide shows the distribution of demographic and related occupational factors according to low back pain status. Gender, height, LVP frequency, and pain severity were significant associated with LVP. In contrast, most occupational factors like rest a week, education level, job satisfaction, physical exercise, prolonged sitting, and length employment were not significant associated with LVP. And similarly, several demographic factors such as BMI and age did not show significant difference between groups. And overall, this finding suggests that LVP in this population is more strongly related to individual characteristics and pain profile than to occupational exposure alone. After multivariable adjustment and controlling for demographic and occupational variables, female sex, genital height, and moderate pain severity remain independent predictors of LVP. Specifically, men had a significant lower odds LVP, height, also strong associated with moderate and tall stature, and pain intensity with moderate pain severity, suggests represent early and clinical relevant state of LVP. These independent predictors help explain why individuals susceptible may outweigh workplace exposure, which we'll discuss next from Dr. Kelly.
Thank you very much for that very interesting study about low back pain and the factors that influence low back pain. I have a couple of questions, but before I raise any one of them, I would like to open the floor for discussion for anyone interested in the audience to raise any questions. Is there anyone in the audience who has any questions? Anyone in the audience, please? Yeah, please.
Assalamualaikum, very good morning. I'm Kazali from Rehab team again. So this study has been in Malaysia.
Yes. I study in Europe.
Okay, alright. So usually there is a standard protocol if you want to identify, for example, any hazard related to office worker. And the standard guideline is actually we will start with ergonomic risk assessment. Right? I can see that first two slide, I think it shows about the ergonomic risk. Right? So did you conduct any era prior to your study? Ergonomic risk assessment. Do you have that in this study? Like a screening, there is like a compulsory screening if you want to identify any office hazards.
No, just I assess the all of participant in office worker exactly in office worker.
Oh, I'm sorry, your respondent is from Malaysia or from Indonesia?
Indonesia.
Okay, alright. So then I will go for recommendation, right? Not a question.
Yes.
So that is a standard that we usually use in Malaysia, but I think in Indonesia they should have the same standard, but they may call it differently. That's what we call an ergonomic risk assessment. Okay, for example, if you want to suggest for modification or anything, we need to identify what is wrong with the ergonomic setup, because ergonomic is found to be one of the significant issue contribute to low back pain. Very, very, has been research for many years. Okay, so I would like to suggest maybe you can discuss with the team from Malaysia to look into the ERA. We call it ERA. So that is a guideline that we need to start with the screening and all those things. And I believe with that screening data that can support, it's going to be very excellent discussion later on, because finally there's one or two points that I think it can be covered if you have the screening data. Okay, so I guess for future, because for the past 3 papers, everything is talking about pain. It's going to be a very painful morning. So next study is related to the pain and risk at the workplace. I strongly suggest to adapt the existing guideline. Then most probably, I think that can support for your future study. Alright, thank you very much.
Maybe I want to add on, because this is my assessment to just for 3 assessment. Then I collect many assessment for ergonomic. I use ROSA.
Oh, ROSA.
Yes,
Oh.
ROSA.
So you use ROSA.
Yes.
Okay. What's the result of ROSA?
This conference I use the
Okay.
assessment.
So you know it.
Yes.
Alright, thank you.
Thank you. Thank you very much for that very elaborate question. We don't have much time to raise many questions, but I have to make an observation from the presentation that you made. In my opinion, I think your study is not focused enough. Given the fact that we already know a lot about low back pain, and the fact that you have included aspects like demography and workplace satisfaction and things like that, I think is irrelevant, because it's already known that low back pain does not come from job satisfaction, demography or anything like that. There are a couple of reasons why low back pain arises. That is partly either natural disc degeneration or misalignment of the disc resulting from posture or the imbalanced spinal loading. Now, I noticed in your inclusion criteria, you excluded those who cannot maintain posture, whereas posture is one of the very critical factors of office workers in particular, because they do not actually carry loads, and resulting in spinal imbalance loading and things like that. So I think my observation is that some of the things that you should have examined are not required to be examined right now, because we already know that demographic factors and workplace satisfaction and stress in the office does not necessarily contribute to low back pain. There are very specific mechanical, biomechanical aspects that actually contribute to low back pain. Nevertheless, I think it's an interesting study, and next time around I think you should focus more clearly on precisely what causes it. And when you make a conclusion, you should make also a very specific conclusion. Because right now what you said was, it is affected by multivariate factors. That really doesn't make that much sense. You really should mention what exactly causes it. Thank you very much, nevertheless. All right, let's move on to the next question, next presentation, which is by Siti Rahima and Abdul Rahim, talking to us about quality of life and burning informal caregivers. So, femoral neck fracture patients. Over to you.
Assalamualaikum and selamat pagi everyone. I'm Siti Rahima bint Abdul Rahim and I'm from University Technology Malaysia. And together with me, and we are going to present together, is Guru Nayu from Universitas Airlangga, Indonesia. So I would like to present our title for our research is Quality of Life and Burden in Informal Caregiver of Femoral neck fracture patients. And I would like to invite Guru Nayu to start first. Please welcome Guru Nayu. almost equally male and female patient, ethnically diverse, and mostly secondary education. And we found that over half had work experience before, and caregiving roles were mainly parents and the spouses, reflecting that typical family-based care pattern in hip fracture population. For the caregiver, we found that predominantly female and ethnically diverse, with most being children or spouses of patients. So this is the result and discussion from our study. So the patient almost equally male and female, ethnically diverse, and mostly with secondary education. They also over half had work experience, and they have caregiving roles were mainly parents and spouses, reflecting typical family-based care pattern in hip fracture. As for the caregiver, we focus on the caregiver. Predominantly, they are female and ethnically diverse, with most being children and spouses of the patient. Many had secondary education, and they are single, not sole give also. Approximately half live with the patient, reported good support, and they are also receiving good information before taking care of the patient. And this is the quality of life of the caregiver. The result, we are using the short form survey as of statistics, and we found that caregiver of patients with femoral neck fracture reported moderate quality of life. And with mental health score slightly higher than physical health score, indicates that while emotional, resilient, and social functioning are relatively preserved, physical limitation and fatigue remain significant challenges. And the finding that highlights that the caregiving responsibility disproportionately affect physical domain. Consistently with the recent study, they are also using the statistics that show caregivers often experience strain in mobility, energy, and also daily functioning. This result emphasizes the need for intervention targeting physical support to reduce the caregiver burden. So for the caregiver burden, there are 5 domains there: time dependency, development, physical health, and emotional health, and social relationship. The result demonstrate that caregiving impose a moderate but multi-dimensional burden, like I said, with time dependency emerging as the most significant challenge. This reflects the constant demand of providing care, which often restrict the caregiver autonomy and social participation. Social and developmental impacts are further highlight how caregiving responsibility interfere with personal growth and community engagement. Emotionally and physical health burden through secondary underscores the strain of prolonged caregiving on well-being. This finding are consistent with recent study showing that time demands and social restriction remain dominant stressor, reinforcing the need for structured support system to alleviate caregiving strain. So, as for the conclusion, our study demonstrates that an informal caregiver of femoral neck fracture patients experience moderate level of caregiver burden alongside generally moderate quality of life. Time dependency and social disruption were the most prominent burden domains, while physically health was more affected than mental health. This finding highlights the significant yet often overlooked impact of caregiving on family members, emphasizing the need for the caregiver-centered support and post-fracture care pathway. As for the recommendation, the healthcare provider should integrate caregiver assessment, education, and also the psychosocial support into discharge training and follow-up care. For sure, I hope that future research should adopt longitudinal and multi-center design to better understand caregiving trajectories and elevate targeted intervention to reduce burden and improve caregiver well-being. As for the limitation, we are aware that there are some limitations like our study is cross-sectional design, limit causal interpretation between the caregiver burden and the quality of life. Data were self-reported, which may introduce recall and response bias. And in addition, the study was conducted in limited hospital setting, restricting the generalizability to other regions of healthcare system. So this is our references. Thank you. I open the question and
Thank you very much for that study of the quality of life of the healthcare providers of making sure. Is there anyone in the audience who has any questions? I'm sure there are. I have some questions, but I will raise them after anyone in the audience raises anything that they noted. Yeah. All of you are in the medical industry, and I'm sure you should have observed things from the presentation which raises questions. No? Doesn't look like there are questions coming from the audience, but I have actually a number of questions. First of all, I think from the observations I made in your presentation, I really did not find that you're looking at the quality of life of the caregivers as you claimed in your presentation title. I was looking at the slide number 6 and 7, in which you were talking about the characteristics of the caregivers, which listed a number of aspects, none of which actually really measured quality of life. So my question is, how did you actually measure the quality of life? Because the point is that you are trying to make an association between the quality of life of the caregivers with the fact that they are actually involved in caregiving these patients. Quality of life of the caregivers does not necessarily depend entirely on the aspect of caregiving, because they are also living a life of their own in other ways. So how did you isolate the contribution they were making in terms of healthcare as a major component of quality of life? Number one, how did you measure quality of life? What are the aspects that you looked at in order to measure quality of life?
Alright, can I answer it? No?
Please.
Alright. As for the quality of life, because my research is focusing on the quality of life and the burden of the caregiver. So for the quality of life, I measure it with the tool, namely short form survey as of 36, which they have two component, physical component, summary score, and also the mental component summary score. From the result that we have, it shows that moderate quality of life with the score for physical component, moderate score for physical component, and mental component summary is slightly higher than the physical component. So I think that is how we measure the quality of life of the caregiver of the patient. And the tools that we have used is validated and reliable.
Right. The other question I have is, how does caregiving affect physical health of the caregiver? Because you concluded that it is the physical health of the caregiver that was affected rather than the mental health. I can understand it is the mental health that is affected. But how do people fall sick physically just because they are caregiving and not mentally affected?
Alright. Why do physical
I mean, do they get fever and various kinds of ailments as a result of caregiving?
Okay, I think that the physical well-being were affected so much because since our study is conducted in the first 3 months of the patient, because the caregiver is quite new to the experience of caregiving things. So, mostly they will found that mostly of the caregiver are female. They don't have enough, maybe not enough energy like male, and I think it's possible for them to have physical well-being affected. Since the patient, we need some, some energy and physical to support the movement, the movement or the follow-up of the patient. Because the patient having hip fracture or femoral neck fracture, they can't move freely. Their immobility, their mobility is restricted. So the caregiver will have to use their own energy to help the patient to perform the activity daily living. Yeah, so that's my answer.
All right, thank you very much with respect to this explanation and presentation. Thank you very much. We move on to the next presenter, which is Nurul Hafiza Sadan Zarwinianti, talking about understanding and interpretation of breastfeeding practices among the female lecturers. Thank you very much. Over to you.
Okay, Assalamualaikum and very good morning to the my dear panel and my best participants. So my name is Nur Hafiza binti Saad, and today I'm going to present my research study. The title of my research study is the relationship between understanding and implementation of breast screening practices among female lecturers at UiTM Puncak Alam. So proudly to say that this is the international collaboration between the Malaysian researcher with the Indonesian researcher. Unfortunately, supposedly today I present with the Dr. Sarwinanti, but due to the health problem, she's not able to present with me today. But I will present for the research study today. Okay, we go to the introduction of this study. So by Mohan et al., breast cancer is the most frequent cancer in Malaysia. Early detection and screening are critical to lowering mortality. Despite working in the hospital, women employees do not have regular breast cancer screening due to lack of knowledge about the disease and the need to have frequent breast screening. Implementing preventative interventions such as screening has the potential to lessen the burden of breast cancer caused by late presentation. This is by Hati et al. Okay, now we go to the problem statement. The majority of cancer deaths are due to delayed diagnosis, with patients presenting at advanced stage during the first encounter with the healthcare. So as a result, many instances are diagnosed at advanced stage, resulting in terrible consequences, including fatalities. So other than that, poor information, awareness, social support, and also the emotional issues and patient demographic advanced stage of breast cancer is widespread in Indonesia. So we go to the objective. So the purpose of this research study is actually to assess the level of understanding and implementation regarding breast self-examination among female lecturers at UiTM Puncak Alam. We would like to assess the level and understanding and implementation regarding clinical breast examination among female lecturers at UiTM Puncak Alam, and to assess the level of understanding and implementation regarding mammography among female lecturers at UiTM Puncak Alam. We also would like to determine the relationship between understanding and implementation of breast screening practices with the family histories of breast cancer. Okay, we go to the literature review. So, raising awareness of breast cancer and self-examination through community program can enhance knowledge level. Market women also with lower levels of education will less likely to perform self-examination, and the level of knowledge and practice of healthcare professionals towards breast cancer screening method are major factors in your patient use of these methods. Okay, we go to our methodology. So this research study is a cross-sectional study design. The population of and sample of our study is 261 participants. Among the female lecturers at UiTM Puncak Alam, we use the convenience sampling, and we use the questionnaire, and we receive full ethical approval approval by UiTM Research Ethics Committee. So now we go to the results. So this table show the social demographic result from 261 participants. So if we can see here, 30 to 39 age, the average age among 41% of the participants. So mostly is from the religion is Islam, 57.5%, and most is married. And here I would like to highlight here there are 224 percentage is no family history with breast cancer. So this is the objective that we want to assess is a level of knowledge. This is a level of knowledge and practices of breast self-examination. If we can see here, 58% awareness regarding the clinical breast examination. So this is the level of knowledge regarding mammography. So if you can see here, 65% have fair knowledge, good knowledge regarding mammography. So this is the correlation. If we can see here, the p-value here, all the three methods have the no significant correlation, because if we can see here, the p-value is more than 0.05. This is shown that there is no associate correlation between level of knowledge practices with the family history of breast cancer. So the discussion for the objective one, a notable percentage of women lack adequate knowledge, which is consistent with findings from other regions. For instance, a study conducted among breast cancer patients in Damascus, Syria, reported that 27.4% of participants had good knowledge of BSE, while majority had low knowledge. So a study conducted by Dinich in Ethiopia reported similar findings, with a substantial number of women exhibited low level of clinical breast examination knowledge and practice. They observed that while awareness about breast cancer was relatively high, the actual practice of CBE was notable low. And the objectively, the relatively high percentage of respondents with fair knowledge and practices, such as a moderate level of awareness and engagement with mammography, which is critically for early detection and treatment. Therefore, targeted educational program and community outreach can be vital in bridging this knowledge gap. So the objective number 4, the finding of this study highlight that there is no significant correlation between a family history of breast cancer and the knowledge and practice of various breast screening methods among the respondents. These underscore importance of broad-based educational and awareness program in improving breast cancer screening practices. So for the conclusion, the findings of this study highlight that there is no significant correlation between a family history of breast cancer and the knowledge and practice of various breast screening methods among the respondents. These underscore the importance of broad-based educational and awareness program in improving breast cancer screening. Yeah, thank you so much. That's all from me.
Thank you very much for that very interesting presentation about the lack of knowledge of breast screening practices among the healthcare workers. And I will open the floor for discussion if there is anyone who has any questions. Yes, there is someone.
I know that you are in the nursing field. So I would like to ask, sorry, I know that you are also in the nursing field.
Yeah.
So I would like to ask why the research conducted on the female lecturer in the university, I mean the whole university, UITM, right? So why not only focusing on the nursing lecturers? Isn't it enough?
Thank you so much. Why we don't conducted this study among the nursing lecturers or in the healthcare related to the health faculty? Because we don't want the biased result. Because as we all know that, of course, the nursing lecturer has a good knowledge regarding this study. So we don't want the biased result.
Alright, thank you. Answering my question.
Thank you. Thank you very much. I think the presentation was clear and you have very clearly established there is a lack of knowledge. But I think a fundamental question comes, which is why is it that there is lack of knowledge among these workers, because they are in the health industry and the information is readily available and it's at hand. So why is that poverty of knowledge prevails? Is there any reason you can?
Yeah, from our research, we find out that maybe the lack of time due to the workload, or maybe they scared with the results, so they don't go for the these three methods by the especially by clinical breast examination by the nurses of the other clinical healthcare. Like a doctor, because maybe they're scared with the results.
Yeah, sure, okay. Because I asked the question because in your literature review you were saying that market women who have poor education don't have good understanding. Understandable because they have low education, but here we are talking of people who are educated in the health industry. So naturally they should have had the access. Nevertheless, I think it's a good study which brings attention to the fact that this needs to be paid attention. Thank you very much indeed. Thank you.
So much.
Let's move on to the next presenter, which is Rabia, Rahim and Anga Wilandika, talking to us about self-care areas among Malaysian heart failure patients in government hospital, talking to establish the demographic influence. Over to you.
Assalamualaikum and very good morning to honorable judges, fellow researchers, lecturers and friends. My name is Rabia binti Rahim from University Technology Mara of Malaysia, and today we would like to share our research title, Healthcare Behaviors Among Malaysia's Heart Failure Patients in Government Hospital. We are focusing on demographic influence. So probably to present by my team is me, myself, Rabia, one Marina, one Ismail, Intan Ashura from Sama, and we are three from UITM. And we have international presenter, which is Dr. Anga Wilandika from Asia Bandung University of Indonesia. So for the introduction, I will pass to my co-author, which is Dr. Anga. So Dr. Anga, the floor is yours. Okay, now we move to the methodology. For this study, we are using the cross-sectional quantitative study design, and the setting was done in a cardiology clinic, Malaysian's government hospital, and the sample was 159 of heart failure patients. They received more than 6 month treatment, and the sampling we are using the simple random sampling, and for the instrument we use the self-care heart failure index version 7.2, which is this questionnaire consists of 3 domains, which is the self-care management, maintenance, and confidence. So this questionnaire also have a good chroma alpha, which is 0.91, and then for analysis we are using the SPSS version 27. Okay, this is the result from our study. For the demography in gender, we can see that the male patient have the highest number, which is 65.4% of the participants. For the age, we have 63.5% of the heart failure patients with age more than 35. And for the marital status, 50.3% of them are married. For the ethnicity, we can see that the Chinese ethnic has the highest numbers of the participants, with the numbers of 49.7%, followed by the Indian for 23.3%, and for the Malay ethnic, we have 16.4%. For the living area, we have the highest percentage, which is 39% of heart failure are living in suburban area. For the employment, we have 64.8% of the participants are employed, and 56% of them are from the non-healthcare related. And for the income, 56.6% are from the range of 1,001 to 1,999. Okay, for the self-care behaviors result, first we focus on the 3 domain first. For the maintenance, they're showing the highest numbers of mean. We can see that they have a 3.87 mean, and followed by the management 3.81, and the confidence we have a mean number 3.84 numbers. And for the maintenance, for the result in the self-care maintenance, the 35.8% of the participants are trying to score. We have 35.8% score for the participant that answered that trying to avoid from the getting sick, and only we had 0.6% of the respondents with themselves check for swelling and keeps appointment. Even though this is a very worried numbers actually, because this routine, we call it the heart failure patients, this is the routine activity they have to do, but we only have 0.6 participants are really concerned about their weight to weigh themselves. Okay, for the management, we have 50.9% of the respondents reduce salt in diet, and only have 0.6% of the participants will call doctor for the guidance. For this, even though they have we have a high number percentage of the reduced salt in diet, but for us in the healthcare setting, this is very quite low. For the confidence, we have 27.7% of the respondents keep free from the symptom and evaluate how well remedy works, and only 5% keep free from the heart failure symptoms. Follow the treatment advice given and evaluate how well the remedy works. For the relationship for demographic and self-care, so we found that person correlation analysis demonstrates a significant positive between age and the self-care behavior. So this indicates that the higher age was modest associated with the higher self-care, which is the older patients, so the good their self-care. But in other demographic factors, there are no significant differences between other demographic, which is the marital status, employment, living area, and the income. for the self-care, yeah, sorry. Okay, for the discussion and implementations, I will pass to Dr. Angga for presentation.
Thank you very much on the
Thank you very much.
very interesting presentation about the heart patients and self-care practices. I don't have any questions, but I assume there may be some questions from the audience.
Yes. Okay.
Yes.
Thank you, Rabia. I have one question only for this topic.
For the self-care behavior among Malaysian heart failure patients in government hospital. And on this study, what is the significance of the finding for the research for you?
Okay, thank you for the question. Okay, for this study, we found that there are lack in some domains. We can see that the lack there's a significant there have a lack in the age of the participants with the self-care. So this study will help to identify the specific area of weakness and particularly in the self-care, confidence and self-management. So in the health setting, we will guide the target educations and program for especially for the youngsters that who have the heart failure to support their healthcare and the self-care practice in the future, especially in Malaysia.
Okay, that's nice. Okay, very good. Thank you, Rabia.
Thank you so much.
Thank you very much for that very interesting presentation. Although some of the material is obvious that if you are older, then you understand issues and take care more. But generally speaking, it's a good study that indicates there is a moderate understanding about the Let's move on to the next presenter. Thank you for the presentation. Let's move on to the next presenter.
Assalamualaikum and a very good morning to everyone. Okay, so me and my co-authors, Miza and Miza, we're going to share on our scoping review paper titled Relationship Between Food Disorder, Disability and Fitness Among Older People with Low Back Pain. Okay, first, background of study. Globally, as we know, low back pain is not only common cases among older people, but it is highly prevalent, as you can see here. The numbers of prevalence of low back pain is projected to 843 million by 2050 from the current one, 619 million in 2020. Okay, and apart from that, low back pain is also a major contributor to disability among this population. Okay, next, elderly. Elderly is commonly represented with functional decline. Okay, in this study, we are looking into three main components. Okay, we go for the first one. The first one will be food disorder. So age-related disorders such as bunion, hallux valgus will then affect balance and mobility, as well as it will alter the gait mechanism. Okay, next we go to physical fitness decline. Okay, normally in aging population we can see a muscle weaknesses and also sarcopenia, where will lead to impact in neuromuscular control as well as reducing physical performance. Okay, so generally both of these changes will cause disability. Okay, most of them will present with reduced immobility as well as limitation of daily activity living. Okay, so the methods of this study, we are using AicQoL framework with guided PRISMA SCR guideline, which include 5 different stages. Okay, first one, the identification of the research question. So the aim of this study is actually to map the existing evidence on food disorder, physical fitness as well as disability in older people with low back pain. Okay, so our main research question here is what is the currently known about the relationship between these 3 variables among older people with low back pain. Followed by the sub-question, we have how do food deformity and food function actually related to physical pain, postural instability as well as mobility limitation. Followed by the next question is what is the evidence exists on these 3 interplay of the food disorder, disability, physical fitness among other people with low back pain. Okay, so to answer these 3 questions, we searched on 3 different databases, which is PubMed, Scopus and Web of Science. So we are looking into 2020 to 2025 current research. So the paper will include with the characteristic of inclusion criteria will be older people with more than 60 years old, presented with low back pain, food, fitness or disability outcomes, English language and full text article, and the article will be excluded if the participants is undergo any procedures, surgical procedures, animal study and non-English paper. So generally what we get here, so only 1,272 papers was included. So after the screening and remove the duplication, only 12 papers were included in this study. Okay, for the key key findings, I will pass this presentation to my co-author, Ms. Liza Anuza.
Thank you very much for that very interesting study that connects the food disorders to the low back pain and the
Thank you for the question. As for me, in my opinion, we generally apply clinically. We have proof that there will be a correlation between low back pain, fitness, and also disability. It's really we know the findings. The correlation is there. However, food may be factors that can seen as it may sorry. So for me, food disorders can also lead to low back pain as well, by changing their ability to control movement and also alter the gait mechanics, where they will then affect the loading on the spine while walking. So there will be a compensation in muscle of lower back as well, and the hip and also glutes.
Yes,
So
we do agree that
it is
there is a relationship without any
Yes.
patients.
So
But food disorder can happen by itself, isn't it, without low back pain?
Yes, because of age-related aging process of the joint, and also the muscle wasting will be presented in elder people. So maybe food disorder will come first, followed by low back pain, or maybe low back pain first, then food.
I agree. All right, thank you very much for the presentation, which draws attention to the relationship between food disorder and
Thank you so
low back
much
pain.
for your time.
Thank you very much. So let's conclude for this session. I'm thankful to all the presenters. We have learned today a lot about low back pain, and then we have heard about anxiety and pain relationship among the arthroplasty patients, and about breast screening, as well as caregivers' quality of life, who are taking care of the patients with femur or neck fracture patients and heart patients and so on and so forth. All the presentations were of highest quality and standards, although there are some drawbacks here and there which we have paid attention to, and hopefully as we progress with future research, some of those aspects would be addressed. So I'm thankful to all the presenters for all the beautiful and very scientific research that has been presented, and we hope to see you again in this conference talking about other issues that are related to environment and behavior. Thank you very much indeed.
Okay, thank you so much.
I conclude this session.
Thank you so much, Prof. Ranjith, for sharing the first breakout session. I hope you are doing well.
Right.
And I hope you enjoy your breakfast.
Of course, yes. We learned a lot about low back pain and heart failures, and breast screening and all the kinds of medical issues that arise, and how people are taking care of them and what we need to do about it. Thank you very much for that great new knowledge that has been produced.
Okay. Thank you, Prof. Enjoy your dinner. Breakfast.
Sure, will do.
Okay. Okay. Now I would like to ask everyone. Okay. We will have a photo session, a group photo session before lunch. So the first group photo we will have in the breakout room, and the second one will be had at front of the hotel.